Okay, thanks for joining us at our student panel discussion of our experiences as clinical psychology students working in across a spectrum of different levels of care, including inpatient settings and integrated primary care settings. We're all in the same program, and we're all current third years in that program. My name is Nora McKennedy, and I'm joined by Steve Metis, Nona Sharp, Emily Stanton, and Jace here.
So we'd like to start with a case vignette, which helps encapsulate some of the themes for today. During a treatment team meeting in the extended acute unit of an inpatient hospital, the staff were asking a patient about possible discharge sites. I think it's important to note that these meetings often had the air of an interrogation, at least in my opinion, and they seemed as though they could be uncomfortable for patients. The patient was seated at one end of the table and asked questions by a group of about 10 people. The patient said that she wanted to return home after discharge from the hospital. However, the patient did not have a home, and it was likely that she would be discharged to either an LTSR or a nursing home. Some of the staff took the tact of directly challenging the patient on this, and the patient became more aggressive and her delusions worsened as a result. By the end of the meeting, she had signed her treatment update form as Dr. Patient. It seemed to me that trying to force someone to admit they don't have a home and will likely spend the rest of their life in an institutional setting is potentially diminishing, and it accentuates the power differential between patient and staff. This patient had no home, was a marginalized individual, and did not have true control over her life and future. I feel that delusions were best understood as an unconscious attempt to bolster a low self-worth. We feel it's critical to approach these moments with empathy and an understanding of how vulnerable these patients are due to their lack of power. This vignette was also not a unique experience. Multiple speakers today have seen versions of this occur more than once. We feel this speaks to how patients are often both consciously and unconsciously aware of their place in the hierarchy, and that it's a good concrete example of how it can come to affect presentations. In traditional psychoanalytic thought, delusions are considered a way for the individual to reconcile the internal and external worlds. For many patients in an inpatient psychiatric unit, the external world has been a harsh, unwelcoming, and deeply traumatic place. Indeed, trauma was a major factor for every patient on the unit I worked on. Related, isolation from others and a sense of loneliness were also driving factors. Psychotic thought can be thought of as an unconscious and maladaptive way of coping with these problems. Paranoia can be initially well-founded and somewhat functional. Grandiosity can have the effect of bolstering a sense of self-worth. However, these can have cyclical, self-sustaining effects, as when an individual's psychotic level symptoms are noticed by other people, they are often further isolated from the community as a result, which promotes a greater reliance on the symptomology. One approach to treatment has been to attempt to interrupt this pattern, to use interpretation or cognitive restructuring to attempt to reframe a person's thoughts. However, another approach is to get to the underlying issues, and central to this is powerlessness. This is perhaps most salient in institutional settings. Being in a hospital is deeply wounding, especially when one has been involuntarily committed. In this case, a person loses agency. A life-altering decision has been made for them. Though they may not agree with it, the consequences of this decision are numerous and lifelong. They become the least powerful people on a unit designed to care for them and may feel particularly vulnerable as a result. The wish to leave the hospital, understandably, becomes a primary goal for most people. Consequently, it is critical to work towards empowering the patient and involving them in decisions about their care whenever possible. Furthermore, this approach should come from an authentic interest and care for the individual. If and when the student and treatment team cannot accommodate a patient's wishes, the reasoning should be explained rather than just insisted upon. Clinicians should also be willing to discuss broader societal power imbalances as well. It is a fact that racial and ethnic minorities and those from lower socioeconomic status backgrounds are disproportionately represented in inpatient settings. Patients are often acutely aware of this disparity, and it can frequently affect their presentations. If a clinician ignores or minimizes those issues, it can have the effect of continuing to enact the oppression. Related, an additional point to keep in mind, perhaps especially as a student or beginning clinician, is the value of basic therapeutic skills. There is, of course, a need to cater interventions and an approach to an individual's specific needs, but listening, empathy, and recognition remain invaluable across all diagnoses and settings. This may be most noticeable when treating those who have been labeled difficult, often due to self-harm and/or aggression. Patients who frequently engage in these behaviors can eventually become distanced or even resented from and by staff and peers. These individuals are usually aware of this and become even more frustrated as a result, which in turn can drive yet more of the self-harm and aggression and then continue further alienating others. Here, empathy and recognition may be even more necessary, as facilitating new, healthier relational experiences that have been encountered previously is essential for treatment.
So thanks, Steve, for starting us off with a great clinical example. We hope that you'll keep this clinical vignette in mind and mentally refer back to it periodically as we continue our commentary, as many of our experiences mirror key elements of this case. So it can be helpful for you to mentally see if you can find similarities between this case example and other clinical material we bring up, and also in your own experiences. So what is our role in various treatment settings? For example, working with physicians, how do physicians see us? Are they threatened by our presence? Do they believe that they need us? Do they see our expertise and our knowledge as adding value? Or are we, in some cases, just babysitters for problem patients? Or do they only call us for emotional patients? So what do we do when the doctor just wants us to reinforce something that they want their patient to do? Do we, in this case, become an accomplice? For example, I've had physicians refer a patient to me with the only agenda of being for us to convince the patient to do something to make some type of behavioral change. So like to quit smoking or eat healthier, to exercise more, to take their medications, or to drink less alcohol. And in a lot of these situations, the patients that they referred to the behavioral health team were not even ready to make any of those behavioral changes. So in that situation, it creates a disconnect, not only between the primary doctor and that patient, but also between myself and the patient I'm seeing and the behavioral health team at large. If we're seen as someone that's brought in to just, again, be an accomplice to the doctor, or to force or coerce a patient to do something that they don't want to do or that they're not ready to address.
Yes, so in primary care settings, this role is further complicated because the patient is primarily coming in for a medical appointment. So the patient's primary relationship is really with the physician. So how does that, again, affect our role when working with these patients? How did the patient see us on top of how did the physician see us? In my setting, I realized we were encouraged to introduce ourselves as behavioral health consultants rather than psychologists or student psychologists. And we realized that's kind of focused on the stigma that's centering around psychology. So a lot of these patients coming in were going in for a medical appointment, may not even be expecting to see, anyone beyond a physician. And then lo and behold, like a student psychologist pops into the room. So to kind of minimize that, I guess, surprise or that stigma, is it problematic that we introduce ourselves as behavioral health consultants, or is that not problematic? It just becomes more complicated.
So,
Yeah.
oh, sorry.
That's okay. I was just going to add that similarly in working with residents, there can also be kind of a similar experience. And I think it can be helpful to consider. And with residency, they usually aren't taught extensively about psychological issues in their respective training programs. So most of what they know about mental illness and mental health is based around pharmacology. So how would a resident view us and view our role or view the behavioral health team, given that all they really know, or mostly what they know about mental illness, is just seeing it as something to be cured or fixed by medication.
So what I was going to say before I interrupted Nona was the rest of what Steve and Nona and Emily have been getting at is are these like patterns of power and authority that are extremely present and feel unavoidable especially in these settings, and I feel especially in where I was in an inpatient acute care setting. So, and the complex relationship that we are negotiating as students, and not only just like students, but as clinical psychology students, and how does that factor into how patients see us, how, as Nona and Emily have touched on, how do other staff within the unit or within the setting view us, and what are what become like our responsibilities in this particular ambiguous role that we kind of fluctuate within. So, and more importantly, how do patients see us? So I think from my experience, I felt like I was floating within this like very ambiguous system and role itself, that was hard to kind of figure out where I was needed the most, or where I would be the most effective for patients themselves. But and that was hard to kind of figure out where and when to interject myself in between this hierarchy of like psychiatry at the top, and then usually like social work and therapy who a lot of times do a lot of the labor, but are seen on like the lower end of the spectrum, especially like in a medical setting, and psychology kind of floats in between those two. So how do patients view us, and how do patients see me as a student? And I think that being a student inevitably has less access to power, and I think that was something that I leaned into, and that I think a lot of patients could connect with, as they are usually even the lowest part of the hierarchy in an inpatient setting. So I think that that ambiguous, confusing role was something that I tried to use as a way to connect with patients that were already existing in this very confusing reality, and kind of worked toward moving away from the power dynamic of someone that wasn't a social worker, or someone that wasn't a psychiatrist, who those were the people that were making the official calls for those patients. And they could see me as someone that wasn't able to make those official calls. Like I could obviously put input, but I wasn't the final call on things like that for them. So I think that was something that they could connect with, especially in more of like a milieu therapy setting of just speaking with patients in a not official therapeutic way, just out in the day room, trying to just have a conversation and see how just like their day was going, unrelated to official treatment.
I think one example that I have of this kind of ambiguity that students have happened in one inpatient hospital that I was working at, where I was on 2 different units. And on one unit, students were actively invited to sit at treatment team meetings and give input, feedback, speak with social workers, psychiatrists, other psychologists about patient care. And then on the other unit at the same hospital, all students had to stand against a wall and weren't allowed to actively participate. We were just kind of expected to sit back and learn. And I definitely see value in, both experiences, but the power dynamic in both really shaped the way that I felt about the units in general. I found myself wanting to spend more time on the unit where I was invited to sit down at treatment team meetings and form relationships with the psychiatrists on that unit, with nurses, and even spend more time with patients there. So I think that it can be really important when we're setting up the dynamics of our treatment systems to think about just how we interact with power and how that can impact how every part of the treatment team is interacting with each other and with patients. And something else I kind of want to talk about is how power and authority dynamics can lead to splitting in treatment contexts. I think an example of this happens pretty frequently with clients that have borderline personality disorder. Institutions can often become polarized around these clients. I have personally found that psychiatrists and psychologists tend to want to get these patients out, especially for patients that have been hospitalized repeatedly, whereas other staff members might be more pulled in by these patients and offer greater support to them. And I think that students can really fall on either side of this polarization, either kind of taking on a more patient advocate role, which might often mean disagreeing with supervisors or adopting the attitude of our supervisors. And I think that this can lead to a lot of role confusion for students, as well as for patients, and patients specifically asking things like how are people viewing me, what behaviors of mine are good or bad, what behaviors elicit care, what behaviors get me, sent home from the hospital. And even like, do I belong in the hospital or not? It can be a really confusing experience. And something I kind of want to talk about is how these polarizations can reflect greater institutional disagreements. And specifically, do people in mental health settings project anger about power within the systems we work in onto patient care? So for example, I often found myself feeling powerless against psychiatrist decisions in inpatient settings, being silenced in treatment team meetings, not necessarily being listened to if I thought that a patient really needed to stay for an extra couple of days. And so, especially around clients with borderline personality disorder, I would sometimes become very convicted about my own opinion and would kind of jump through extra hoops to get my point across, talking out more in meetings than I usually would, kind of excessive documentation and making sure other staff were doing this excessive documentation of, like self-harm, suicidal ideation, things like that. And while I told myself it was entirely for the benefit of the patient, which I do still think it was for the benefit of patients, reflecting on it, I think that these dynamics was also part of a way for me to assert my power on the units, and even as a way to amplify the voices of members of the treatment team that had less power than I did. So I think it's just important to keep in mind how we're letting system dynamics impact the way that we are talking about patients and making decisions about patient care. Because how does this splitting impact patient care, especially when students are polarized against other members of the treatment team, like their supervisors? Patients might have more positive relationships with students than they have with their psychiatrists or other psychologists, which for students can feel really good, but ultimately might not be helpful for patient care. We're only there for a limited number of days. We, have less knowledge of intervention than other psychologists on the units. And by establishing ourselves as different from the system, we might even be encouraging patients to see us as good, but their general treatment as bad, which can, potentially encourage black and white thinking that is already happening for these folks. And I also wonder if students' tendency to split from the treatment team might sometimes be a way to disavow our own role in maintaining systems. I think all of us can, not only students, but all of us see a lot of problems in mental health care systems. But students are ultimately still a part of the system. We're working under our supervisor's license, and in a few years we are gonna be the psychologists that are the system. And I wonder, how can we incorporate this into our identities in order to enact systemic change rather than disavow this part of ourselves and just kind of maintain these dynamics?
Yeah, so in terms of power dynamics and the fluidity of who has different levels of power and what situations, some questions to think about just in general are, what is our role? What is our role in reality and functionally? What are we called to do? And ideally, what do we think our role should be? And what do we think we should be doing? How do we ensure that our voices are heard in the spaces where treatment decisions are being made? And what's the harm if our voice isn't included in treatment planning? And are we seen as a voice of authority in our field with a distinct and unique knowledge base that's truly needed? Are we acting as agents of an unjust system? It may be comfortable to think about that, but in many cases we are. And how do we reconcile this within ourselves? And how do we manage these reactions?
Yeah, so to further our discussion of, role and power dynamics, it's worthwhile to understand how and why certain language has come about in our field. Psychosis is often thought about under this umbrella of severe mental illness. So as a group, we became curious about where that phrase came from, severe mental illness. And essentially we found out that like a primary purpose of defining serious mental illness was to distribute mental health grants in support of persons with serious mental illness. And actually we've found out that not the exact opposite basically happened. So in the United States, mental health spending and mental health nonprofits focus almost exclusively on people who don't have a serious mental illness rather than those who do. And when we talk about serious mental illness, that grouping has been kind of covering, people with schizophrenia, bipolar disorder, and severe depression is what we were able to find out. And there are consequences essentially of defining a group as severe or serious, however you want to think about it. And I actually wondered about what those consequences can be. And I think part of labeling a group as serious or severe almost allows us to write off this group. Because if in my professional opinion, I can label something as severe, then that essentially gives me room to not succeed in treatment. Because then I can just say, well, this patient is just a severe case. And you can kind of see that, I think, in our history of how we've treated people with severe mental illness. So and a lot of the techniques include pretty inconsiderate, dehumanizing, sometimes even just lazy approaches, like giving people pills essentially just to deaden their symptoms because we feel like we can't handle it another way. And even with ECT, like literally shocking people's brains to induce seizures, but we write it off as a last-ditch effort. But by saying we try to only provide this sort of extreme treatment to the most severe cases, it somehow becomes legitimized. But the opposite of that, it comes at the cost of skipping over these person-centered and non-invasive treatment methods like talk therapy that we do with all of these other patients, because we might have this assumption that they're not even worth trying. And clearly our clients are likely to disagree.
Yeah, and in my experience, similar to what Emily is just talking about, is in an integrated prac site. A lot of the patients with borderline personality disorder, bipolar disorder, and schizophrenia were seen as problem patients right off the bat. They were referred to as frequent flyers or clients that were draining the system, or seen as super utilizers, which is common, language in the behavioral health atmosphere. So in my experience, most of the doctors that I was working with and working alongside, they would go into these appointments already having the mindset of, okay, this patient is going to be difficult. They're going to take up a lot of my time. And that's a big issue in, medical and primary care settings. And right off the bat is that doctors only have a certain amount of time with patients. Their time is very limited. And so a lot of the times the doctors would just assume that these clients were going to be the ones to set them behind schedule and kind of, mess up the flow that they already had going for other patients. So they would go into these appointments a lot of the time with a negative outlook. And then they would refer those patients to myself or to another behavioral health consultant without even having taken a full history sometimes, or not completing an exam, or even attending to the issue that the client came in for. So, that hurts our patients. And I think it's important to address, how we and how especially our medical counterparts see clients that have these diagnoses, and how we, work with them and how we work together to address certain diagnoses, and, how we see severe mental illness.
So going off that point of kind of critiquing the impacts of diagnosis, is obviously that the symbolic power of diagnosis has very tangible, real implications for the patients that carry these diagnoses in their charts, for people that are considered frequent flyers, or these more severe cases that are often, like we said, written off because of usually the diagnosis that is attached to their experience, is at the further intersection of usually race or ethnicity, and who and how that that diagnosis is further used as marginalization, and another reason to write off a patient. So especially with diagnoses that are labeled as more volatile or more annoying, or more or definitely there's no cure, there's no treatment that's ever going to help this person. So it's even more striking when these diagnoses appear on certain patients that carry already marginalized identities, which I saw a lot on my unit. When patients, I was at a regular, just a hospital that happened to have an inpatient mental health unit within the hospital. So a lot of patients that were coming were not seeking services, not seeking mental health services, but were walk-ins at the ER and then were transferred to our unit. So a lot of times if someone was coming in as angry or extra demanding or written off as bold or inconsiderate or volatile or dangerous even, they were coming up to our unit already with a security one-to-one, without anything happening, without any, I mean, I guess verbalizations of being angry, but no real evidence of needing a full security guard 24/7 to protect staff and the patient themselves. But and I understand that those are important things, but it was just the frequency at which these precautions were put into place with especially Black women that were deemed as angry or had a history of being angry or fighting with staff. And that really led me to question on who got to experience their symptoms fully, who was granted the space to be angry, who was allowed to like explore that anger and find other reasons for that anger, or who was just shut down immediately, and just continued this cycle of like enactment of just these enactments that were just completely this exact same of how they were treated outside of the unit, just inside the unit now, just not allowing space. And what did that mean for their overall treatment, if any treatment was given?
So similarly to what my colleagues have said, there's a temptation to view individuals with serious mental illness as fundamentally other. Sometimes an individual's experiences can be radically different from our own, and then as a result, they can even be caricatured as frightening. Perhaps consequently, the first time working with someone with a psychotic diagnosis can be intimidating, even for experienced physicians. I'd like to discuss a recent timely example of how this feeling and the label of serious mental illness has intersected with the ongoing coronavirus pandemic and how the issues we've discussed have been prominent. Despite my student status, I was able to return to my site through telehealth after a brief interruption and stayed on through the summer. The pandemic, as is often historically true of diseases, hit the most vulnerable parts of our population disproportionately. The hospital was located in a part of the city that was a hotspot for COVID, and the top floor was turned into a COVID unit. We attempted to take precautions to keep patients and staff safe in the extended acute unit. However, some of the patients did wind up contracting the virus and had to be moved and quarantined. The doctors on the unit felt ill-equipped and unprepared to handle psychosis while also treating coronavirus. As a result, these patients were treated differently and were more quickly discharged from the COVID unit than would be ideal. Patients were returned to the EAU while still testing positive for COVID, and in one case, while still showing clear symptoms. The EAU was forced to try to make an ersatz quarantine from one end of the hall, but unsurprisingly, more cases emerged. I wonder if this is emblematic of how healthcare often treats serious mental illness. While the current circumstances are a struggle for so many of us, it can become even more difficult when dealing with the difficulties and stigma of these diagnoses.
I think that's a really salient example, and to try to tie back together, I guess, the impact of the language in our field. They're essentially hallucinations and delusions are often spoken about as a detachment from reality. And like Steve was saying, this can really accentuate the difference between doctor and patient and lead to that othering that can happen. So, as a treatment provider, if I tell myself, I have a good grasp on reality and your reality is different than mine, so therefore it must be wrong, or I can assign it as a clinical symptom because it's really not mine. I don't share that experience. In an article that was published in 2017 by Garcia, it was basically found that when members see each other as sharing an identity status, they're essentially more able to recognize the similarities between them, and vice versa. If they see another member as not sharing an identity status, they're more likely to basically notice the differences between them. in that study, it was focusing on, racial and gender identity categories, but I'm just wondering if that same sort of thing can be applied to these doctor-patient relationships in terms of reality. Because my reality is seen as so different from you, and maybe I'm saying my identity as a treatment provider is different than your identity as a patient, am I more likely to essentially notice those differences between us, which can be harmful, to not really try to be unable to, I guess, identify with the patient in a way that can really help to understand their experience. So again, this language, this detachment from reality, makes it easier to differentiate between you and me in that othering, rather than notice the similarities. So I think what could be really helpful is if we could move towards interpreting hallucinations and delusions, which has been done, but more move towards this as seeing them as manifestations of anything from loneliness, fear. I think Steve mentioned like low self-worth. So essentially trying to think about these things as things within the realm of human reality, rather just than, my reality versus yours.
Yeah, so far in our presentations, we've talked a lot about ways to think about challenging the systems that we're working in, challenging and critiquing the systems and the structures that exist right now. And we also wanted to touch on some resources that we can call on to actively, promote change and to really become, healthy members in our treatment teams, and at the same time, remaining strong patient advocates. So something that I found in my experience at an integrated care site, something I found to be helpful and a really strong resource was knowing the population and being able to adapt to the population. So just having that approach of adaptability and flexibility, and having a really, strong knowledge base of the person served. For example, serving non-traditional patients poses unique challenges. So, that's why it's very important to understand your population and know some of the things that they're going through outside of the treatment office. So, for example, what's the makeup of the neighborhood or the area in which your practice is situated? What's the ethnic makeup of the majority of your clients? What's their socioeconomic status? Even knowing things like what bus routes are nearby, and how a lot of your clients are getting to the office. Is there local food available, or are most of your clients living in areas that would be considered food deserts? What types of jobs and industry do most of your patients work in? So all these things are important to know, and depending on geography and a host of other factors, it will, have a direct correlation to your client's needs. So in, my experience, the majority of our clients were living below the poverty line. So a lot of common problems that we were seeing were eviction and, consequently frequently moving, and having, many changes of address, lack of reliable transportation and depending solely on public transit or even, rides from friends and family members, lapses in insurance, lack of childcare, especially for clients and families that had multiple children, cell phones being, turned off or disconnected, having clients who were parents that were working multiple jobs just to make ends meet, who also had to, after a long day of work, help with homework and make dinner and all these different things. And in general, patients really had a lack of understanding of the health systems, and also, a lack of strong understanding of their own diagnoses. So, these issues led to, real hurdles that the behavioral health team had to overcome. So, in essence, what do you do when you're seeing the same type of issues come up in multiple patients every day? That would lead you, to change the system, to make some changes. So it's important to welcome flexibility, be open to change, and be open to adapting based on the needs of your population. So at my site, this led us to basically go back to the drawing board, and pretty much change most of how we were doing things. We changed our whole referral process of how, primary doctors would get in touch with us and refer their patients to us. We created drop-in hours to be used for clients that needed to be seen, without having made an appointment. So I know in many cases, it's customary to just have, a schedule of the clients that you're going to see on a given day, and, really expecting clients to remember that they have this, psychology appointment and then this primary doc appointment, all these appointments at the same time on different days. That whole scheduling, navigating the scheduling in that way can be very difficult for a lot of patients. So we really had to just kind of adapt a more flexible schedule of dropping in whenever someone needed to be seen. We also had to adjust the 3 strikes rule. So really evaluating on a case-by-case basis, who were the clients that were going to be referred out to somewhere else, or who were the clients that we were going to keep on our caseload. And we also had to create pretty much a new system for flow of information between clients, patients, the behavioral health team, and even the front desk, who a lot of the times were doing the scheduling. And then we also developed, backup plans and considered different things for who the patient would want us to contact. If their phone was disconnected and they weren't having phone service at that time, how would we get in touch with them, or how would we remind them of an appointment, or even just how would we check in on their symptoms, if they didn't have a phone for a certain amount of time. And with that, how could we contact other people in their life while also maintaining HIPAA compliance? So those were a lot of things that we had to really think about and consider, and also be open to changing.
So one of the main, most invaluable resources that I found to be most helpful in my training and to be most meaningful in my experience in the inpatient setting as a practicum student was developing relationships with other therapists on the unit. And I found that engaging and learning from people that weren't in my field, that were different types of therapists, like music therapists, art therapists, movement therapists, were awesome, because I would never be able to have access to that information otherwise because of being in a clinical psychology program. So I'm so grateful to have been able to engage with those relationships and to learn from people that have a particular expertise that I can't officially do in my practice in the future, but hopefully I'll be able to engage with some of the material and adapt some of their perspectives and their knowledge into my career as a future psychologist that might be more impactful for patients depending on their specific needs. And so establishing those connections was incredibly impactful for me as a student, especially coming in to the unit where group therapy was one of the main therapeutic interventions aside from medication. I had absolutely zero experience with running group, and I felt awful about that, and I felt incredibly guilty that I was one of the main sources of therapeutic intervention, where I was basically just winging it and hoping for the best. And so in order to kind of combat that, I would sit in on the other therapists' groups sessions and try to just see what they were doing, how they'd engage with patients, what kind of topics they brought in, and trying to figure out how effective group therapy is conducted. And that was where I began to foster those relationships. And not only was it helpful for me, but I think hopefully it helped me become a better therapist and group therapist for the patients that I was seeing, instead of just learning. I'm obviously learning on the job as a practicum student, but at least with some backup from people that knew what they were doing, which was amazing for me, and hopefully helpful for my patients, and hopefully helpful for people that I work with in the future, that I can incorporate other knowledge from other fields that I wouldn't have had access to as just a student in a purely clinical program.
Yeah, Nora, I completely agree with your the importance of these relationships that we build, not just with our patients, but with everyone else in that setting. It was very salient in my integrated primary care setting as well. My supervisor harped on me all the time to, do everything I could to build relationships with the residents, not just by having discussions about patients, but by, sitting with them at lunch, talking about their program, just getting to know them better, to really just build that relationship with the ultimate goal that hopefully that goes back to the patient, helping the patient get the best care that they can. I think in our role, trying to push our way into like these medical settings where, you know, we're not at the top of the hierarchy always, and we have to kind of fight for that respect. You know, we might want to build that connection with our patients and connect with every patient that comes through the door, but like we had talked about before, you know, the patients are coming in seeing, you know, the medical physician, they're coming in for a medical appointment. So you know, our role in those settings may not be to essentially handle any and all of those behavioral health concerns that come in, but to really teach and guide the other medical professionals to manage them effectively on their own, in ways so that that the patient is not further harmed.
Yeah, I definitely agree, and I found that the role of a good supervisory relationship cannot be overstated. I felt more confident to be able to act as a patient advocate because I knew my supervisor would back me up. My supervisor was a respected senior member of the treatment team. She modeled and valued an interdisciplinary approach and a team atmosphere. I was encouraged to build relationships with other team members and seek their help and expertise. Consequently, when I did act as a patient advocate, it was harder to dismiss my concerns. Furthermore, it is true that the American healthcare system can leave mental health workers prone to being overworked, underpaid, burned out, and systemically undervalued. This can cause a breakdown in empathy and even confrontation with patients. However, it is also true that many people specifically choose to become staff because they care about others and their mental health. The staff in inpatient units can be truly extraordinary, inspiring people. They are also usually directly on the unit for more time over a longer period of time than a student can be. This time affords the ability to develop a deeper knowledge of and stronger relationships with individual patients. By building relationships with staff, a student not only gains the expertise and input from different disciplines, but can also get assistance building their own relationships with patients and ultimately optimizing care.
I really agree with what everyone has been talking about in terms of building a relationship with other folks on the unit, whether it's your supervisor, other staff, people from other disciplines. And I kind of want to bring that back to a point that Nona brought up about learning the background of patients. I think that can also be really important for the team that you're working with. Just kind of getting a good understanding of where your social power falls in relations to other folks on the treatment team across dimensions that aren't just, you know, whether you're a doctor, a student, but, you know, really thinking about race, thinking about gender, thinking about socioeconomic status. And also, you know, as a student, when we're coming into these treatment settings, who are we like helping in terms of workload? Who has to run less groups because we're there? Who has to write less notes? And who's getting more work because of us? You know, I found that I sometimes am taking rooms away from social workers on units when, you know, individual rooms are really hard to come by in some places, that nurses are having to take extra time to show me around, to unlock things for me if I don't have a key to a certain area, to find paperwork for me. So it can just be really important to, you know, really figure out who you're helping by being there and who you're not helping by being there. I think it's really unhelpful for students to kind of blindly conform with systems that are in place, and that students should have a greater understanding of the impact of our presence in order to have a meaningful role in treatment teams and with patient care.
Thank you, and we'll see you for questions.